the classroom, so you can use it for your final exam. Visual sensor pathways. This is the connection between the eye and the primary visual cortex. And here we have the optic nerve. After that is the chiasm. After that is the optic tract. Lateral geniculate body or nucleus. After that, visual radiation and the primary visual cortex in the occipital lobe of the. About 40% of the human brain is involved in the processing of the visual information. And here is the anatomy of the nerve. Optic nerve is composed of the axons of ganglion cells in the retina. In the retina, we have almost 1 million ganglion cells with 1 million axons, and these axons, they form the optic nerve. The optic nerve has 4 parts. The first is the intraretinal part of the optic nerve. This is the head of the optic nerve in the retina. After that, we have the orbicular part of the optic nerve in the orbit. After that is this part that is in the optic channel. And the fourth part, this is this part that is in the brain. After that, we have here the chiasm of the visual pathways. You know that half of the nerve cross in the chiasm. These are the nasal parts of the optic nerve, and they cross in the chiasm. The temporal, the peripheral part of the optic nerve don't cross in the chiasm. After the chiasm are the optic tracts. The optic tracts are formed from stones of both eyes. Here is the lateral geniculate nucleus, and here is the fourth neuron of the visual system. After this lateral geniculate nucleus starts the visual radiation, and here is the visual cortex. Segment, the optic nerve, the optic chiasm that is close to the pituitary gland, and a retrochiasmal segment that can be pregeniculate, this is before the lateral geniculate nucleus, and retrogeniculate after the lateral geniculate nucleus. In the visual system, we have 4 groups of neurons. 3 of these neurons are in the retina. The first neurons are the rods and cones. You know that the rods are about 60 millions and the cones are around 3 millions. The cones are mainly in the macula and fovea, and the rods are mainly outside the macula in the periphery of the retina. These rods and cones transform the visual stimuli in nerve impulses. Rods and cones have connections with the B-power cells. There are about 10 millions, and this is the second neuron of the visual system. B-power cells make connections with the third neuron of the visual system, and these are the ganglion cells and their axons form the optic nerve. The last neuron of the visual system is lateral geniculate nucleus or body in the brain. And here again, picture. Here is of the optic nerve. Here are the nasal part of the retina. Here are temporal, the axons of the ganglion cells in the temporal part of the movement. This is the macula. Have the biggest part of the cones in the retina and the biggest part of the axons from the cones. Here in the optic, the artery and vein, central retinal artery and central artery vein. This is called excavation. Normally the excavation is not more than 0.3 diameter. And if the diameter of the excavation is greater than this 0.3, we think about glaucoma. Now we examine the function of the optic nerve. We are examining with perimetry. We are examining the light sensitivity of the retina and the light sensitivity of the optic nerve. Here we have something very interesting, and this interesting is that with left visual field is seen by the nasal part of the left eye and with the temporal parts of the right eye. The right visual field is projected on the temporal parts of the left retina and the nasal parts the right retina. So here, after the nasal parts of the optic nerve are crossed in the chiasm, here we have the left optic tract, and this left optic tract transmits the information right visual field, and the left optic tract will transmit from the left visual field. When we have the right or the left eye, when we have pathology in the chiasm, here we will have heteronymous hemianopsy. If the problem is in the nasal parts of the chiasm, we will have a lot of the temporal parts of the visual field, and we will have bitemporal hemianopsy. In these cases, when we have patients with bitemporal hemianopsy, we must think about some pathology of the pituitary gland. In most cases, these are adenomas, benign tumors in the gland. When we have nasal hemianopsy, we must think of pathology in the temporal parts of the chiasm, where are the temporal parts of the axons of the optic nerve. Here we can have a pathology, atherosclerosis of the internal carotid. Well, corpus geniculate in the or in the optic radiations, we will have homonymous hemianopsy. They can be left or right, depending on which part of the left or the right post-chiasmatic structures are destroyed. Okay, and here, prechiasmal or lesions of the optic nerve, we have ipsilateral defect of the site of the lesion. If the problem is in the chiasm, we have temporal engagement of the temporal parts of the visual field when the problem is with the pituitary gland, or we will have engagement of the nasal parts of the visual field if we have some pathology of the internal carotid arteries. The retrochiasmal lesions, we have engagement of the contralateral visual fields, and here the hemianopsy is homonym, or right in the chiasm we have temporal or nasal edmus hemianopsy. In most cases in childhood we have prechiasmal lesions because of trauma or tumor in the optic nerve, and rarely chiasmal lesions when we have tumors of the pituitary gland or other tumors. In older people, the most problems are retrochiasmal lesions, and they are due to ischemic attacks in the brain. Here again, this is the optic nerve, the head of the optic nerve in the orbit, and can be damaged very easily after blunt or open trauma of the eye or the orbit. Here is this small part is the intracanalicular portion in the optic channel and the intracranial portion before the optic chiasm. Optical chiasm, here we have 53-55% of the fibers are crossed in the chiasm, and we have tumors. We're going to have bitemporal heteronymous hemic with the have nasal heteronymopsy. Here in when we have problems with the optic chiasm, here we have the highest risk of irreversible vision. Optic tract from the nasal parts of the axons, the contralateral optic nerve, and the temporal part of the ipsilateral optic nerve. Again, the right optic tract transfer the information from the left visual field, and the left optic tract transmitted the information from the right visual field. Lateral geniculate body, here is the last neuron of the visual system. And optic radiation is the lateral geniculate nucleus and finishes in the primary visual cortex in the occipital lobe. And the visual cortex, here we have primary and secondary cortex centers where the whole visual information will be transformed. And again, the higher cortical areas, and here we are talking about, if we have damage here in the higher cortical areas, we are talking about here we don't have anatomical blindness, but physiology blindness. Optic nerve trophy. Here you can see that the head of the optic nerve is very pale. Normally the head of the optic nerve are clear. The optic nerve is pink with well visible small blood. The atrophy will the head of the optic nerve will be pale and sometimes the borders of the head of the optic can't be seen very easily. We have two types of optic nerve atrophy, primary and secondary atrophy. Primary atrophy of the optic nerve can be seen after optic neuritis, compression opticopathy, directly over the optic nerve, traumatic opticopathy, or hereditary opticopathy. Here in this section for hereditary opticopathy, we have two types of the diseases. One of the hereditary opticopathies are autosomal dominant inherited, and the other one, so-called Leber opticopathy. Here the problem is with the DNA in the mitochondria of the person. Secondary atrophy we can see only after pupil edema, after we have edema of the head of the optic disc. This can be seen in idiopathic intracranial hypertension. We have hypertension in cranial hypertension without space occupying this. It is specific for for girls and young ladies that have obesity, and the main complaints of these young ladies and girls are headaches, awful headaches, and edema of the head of the optic disc with low visual acuity. In these cases, when you see edema of the head of the optic nerve, it's mandatory to do MRI for excluding space occupying process. When there is no space occupying processes, you're thinking about this intracranial hypertension. It is benign condition because you don't have tumor, and here the treatment is diet for the obesity and carboanhydrase inhibitors drug for lowering the intracranial pressure. The optic nerve atrophy can be partial, just part of the optic nerve and part of the head of the optic nerve will be with atrophy, and total atrophy of the whole optic nerve and the whole head of the optic nerve. In most cases, when we have partial atrophy, it is primary. After optic neuritis, after trauma or compression of the optic nerve, or after in the course of one hereditary optic path. Here, in most cases, we have temporal failure of the optic disc, and it's very important, preserve visual functions. When we have partial atrophy, the visual acuity of our patient can be normal or nearly normal. When you have total atrophy, the whole head of the optic nerve is wide, and here we have lack of visual functions. Your patients will be blind. Pupil edema, or edema of the head of the optic nerve. You can see here that the borders of the optic nerve are not clear. You can't see the borders. You can see that the veins are dilated and with some tortuosity. And the head of the optic nerve will not be on the level of the retina, but in front in the vitreous body. When you have this picture of swelling of the optic disc, you must think about increased intracranial pressure. It is mandatory to do MRI to exclude space occupying process, to exclude tumor or other cyst or other of the in the brain, or to exclude benign or idiopathic intracranial hypertensions. In most cases, when we have this picture of pupil edema, we have the process and this swelling of the optic disc is because of increased intracranial pressure. The both eyes are affected. If we have pupil edema just in one of the eyes, we must think for ischemic opticopathy. And again, a picture of pupil edema. This is a case of an 8-year-old girl with idiopathic intracranial hypertension. See these pictures. The borders of the head of the optic nerve are not clear. See the veins, how dilated and with tortuosity are these veins. This is an awful picture, and when ophthalmologists see this picture of pupil edema of the both eyes, we know that this is a serious condition, and it is mandatory immediately to do consultation with neurologist and to do MRI. Optic neuritis or inflammation of the optic nerve. It can be because of autoimmune disease. This is demyelinating type, and the most common reason is multiple sclerosis, or it can be due to infectious viral or bacterial. Here we have acute onset. Your patient will tell you that acutely he lost his visual acuity, that he has some problems with the visual field, and very specific pain with eye movements. Don't forget, you can have optic neuritis with normal visual acuity, but in every time when we have optic neuritis, we have visual field defects. Most of them are non-specific. But here, the pain with the eye movements is very, very important. In most cases, when we have optic neuritis in children, it is infectious because of viral or bacterial infection, and it is watery. When you have optic neuritis in adults, in most cases, it is due to autoimmune disease, due to multiple sclerosis, and in most cases, it is unilateral disease. Okay, here. This is one table from the one big clinical trial. It is optic neuritis treatment trial for patients with optic neuritis because of multiple sclerosis. In most cases, when we have optic neuritis due to multiple sclerosis, our patients are women. You can see here 77% of the patients are women. It is more specific for the light race than the other, for the Caucasian race than the other races. And you can see here that the profile of the patients with optic neuritis are young women, about 30 years of age, and the presence of pain. The main complaint, loss of visual acuity with pain with every eye movements. Ophthalmoscopy findings, in most cases you have normal finding. The patient doesn't see anything and the doctor doesn't see anything in the retina of the patient. The second most common clinical finding is pupil edema. But here the pupil edema is monocular, not binocular, as is the pupil edema when we have space occupying process in the brain. Sometimes you can have retinal or optic disc hemorrhages or retinal exudates. Here you see that 11% of the patients with optic neuritis have normal visual acuity, and just 3% of the patients are with no perception of light. But in all patients, we have visual field defects. All of the patients. If you have normal perimetry, no defects of the visual field, you can't think about optic neuritis. In optic neuritis, pain and visual field defects are mandatory. The visual acuity can be normal. And sometimes you can have problems in the other eye, but because the problems in the other eye are not so specific as the eye with the optic neuritis, the complaints of the patients are in most cases problems with just they are talking just about one eye problem. When you have a young woman and she tells you that there is pain in the eye with every eye movement, that there is something with her visual acuity, think about optic neuritis. Do perimetry to examine the visual fields, and after that make MRI to see the plaques of demyelination that are specific for multiple sclerosis. There is treatment for multiple sclerosis. And don't forget that the optic neuritis can be the first sign of multiple sclerosis. When we have optic neuritis, and this optic neuritis, the most important thing is to conduct blood tests to rule out a viral infection. If we don't have viral infection, we can start treatment with intravenous methylprednisolone. In adults, is post-therapy for 3 days at 1000 milligrams, and for children 3 days for 250 or 500 milligrams. If it's necessary, you can start systemic antibiotics when the reason for the optic neuritis is not an autoimmune disease, but some bacterial infection or antiviral treatment, most often herpes or cytomegalovirus infection for the presence of viral infections. Corticosteroids are just in cases when we are sure that there is no infection, bacterial or viral. And after that, we can start with this post-therapy. In the other cases, we must treat our patients with antibiotics or with antiviral treatment. The next disease is ischemic optic neuropathy. We have 2 types of ischemic optic neuropathy. The first one is non-arteritic, or here we have cardiovascular risk factors, and the other is arteritic with vasculitis, with inflammation, autoimmune inflammation of the blood vessels. Non-arteritic intraocular optic neuropathy is specific for older people with different cardiovascular risk factors: hypertension, diabetes, hypercholesterolemia. When we have arthritic ischemic optic neuropathy, this is is one of the symptoms of giant cell vasculitis or temporal vasculitis. In arthritic ischemic optic neuropathy, your patients will have complaints from headache and ache in the face, and with acute decrease of the visual acuity. When you have non-arthritic ischemic optic neuropathy, the only complaint of your patient is from sudden decrease of the visual acuity. Both of the ischemic optic neuropathies can be anterior or posterior. When you have anterior ischemic optic neuropathy, you are going to have edema of the optic disc, and you will see this edema. Again, it's monocular. When the problem is in the posterior parts of the optic nerve, you will have normal head of the optic nerve without edema. You are not going to have swollen optic disc. Here again, you're examining the visual acuity. You're going to have low visual acuity, and you must do perimetry to see the visual field defects, and also we are going to have afferent pupillary defect. When you have arthritic ischemic optic neuropathy, it's mandatory to start immediately with pulse therapy with steroids to try to decrease the inflammation. When we have non-arthritic ischemic optic neuropathy, in most cases, we can try with steroids, but in most cases there is no treatment for this ischemic optic neuropathy. Here, in non-arthritic ischemic optic neuropathy, is very, very important to treat these cardiovascular risk factors, because there is a high risk for optic neuropathy and in the another eye. Non-arthritic ischemic optic neuropathy has better prognosis for the visual acuity than the arthritic ischemic optic neuropathy. Most of the patients with non-arthritic ischemic optic neuropathy will have some visual acuity, but in arthritic, if there is no treatment with steroids, this eye will be blind. And compressive optic neuropathy. Here we have direct compression of the optic nerve caused by primary brain tumors or non-neoplastic intracranial space occupying processes, cysts, hemorrhages, or abscesses in the brain. Here we have direct compression on the nerve tissue or increase in internal cerebrospinal fluid pressure, but again on the optic nerve. Therefore, here we will have primary atrophy of the optic nerve without pupil edema. When you have trauma of the head, and especially in the area of the orbit, always think about risk for traumatic optic neuropathy. Even small trauma in the orbit region can cause traumatic optic neuropathy. And It can be a complication in 2 to 4 to 5% of the patient with traumatic brain injury. To confirm the diagnosis, it is necessary to exclude other ophthalmological causes of impaired vision, which may also be traumatic cataract, vitreous hemorrhage, retinal detachment. The patient will tell you that he can't see anything with this eye, but be sure what is the reason. Is it traumatic optic neuropathy, or you have something else after the trauma? Here we have one case of a girl with traumatic optic neuropathy. You can see here that the eyelid is dropped. You have ptosis of the upper eyelid, and see the girl can't move her eye. When we have this picture of ptosis and problems with the eye movements, you must think that the oculomotor nerve has some problems. You have paralysis here of the oculomotor nerve, and not just paralysis of the oculomotor nerve, but here we have traumatic optic neuropathy. This eye is with very, very low visual acuity. What we must do here? We must start treatment with corticosteroids to try to lower the pressure of the optic nerve, and to try to decompress the optic nerve. Here it's mandatory to start with these steroids to try to minimize the visual impairment. But don't forget, even small head traumas can cause traumatic optic neuropathy. Therefore, when we have head trauma, if you have a head trauma, you must consult your patient with an ophthalmologist and to think about the possibility for traumatic optic neuropathy. And here, other optic neuropathies, hereditary Leber's hereditary optical pathy. It's specific for young men. It is due to a defect of the DNA in the mitochondria. Or we can have hereditary optical pathy that is autosomal dominant. And when we have autosomal dominant hereditary optical pathy, it can be seen in girls and in boys. But the Leber's hereditary optical pathy is specific for the males. You can try to there are treatments for Leber's hereditary optical pathy. Most of them are clinical trials, but for the autosomal dominant hereditary optical pathy there is no treatment, and these patients very slow lose their visual acuity and their visual function. You can have nutritional optic neuropathies and toxic optic neuropathies. And now the section for the lesions of the optic chiasm. In most cases, they are compressive because of tumors of the pituitary gland, and 2% of the lesions are due to trauma. Here, if you have bitemporal heteronymous hemianopsy, think about compressive chiasmal syndrome. In most cases, your patient will tell you that for months or years he he has had the feeling of heaviness in the head, headache, sometimes nausea and vomiting, before reporting the visual discomfort or blurred peripheral vision. When you have hormonally active, this is in cases when the adenomas of the pituitary gland are not hormonally active. If these tumors are hormonally active, the leading symptoms are of the affected organs and systems: galactorrhea, amenorrhea, diabetes insipidus, and Cushing syndrome. Every patient that is diagnosed with compressive Chiasm syndrome must have his perimetry to examine the visual field and to examine if there are any visual field defects. And here the problem is that these visual field defects are irreversible, but it's important the patient to be operated or treated on time because we want to preserve some visual field. Okay, in most cases, this compressive Chiasm syndrome is because adenomas of the pituitary gland, and 50% with craniopharyngiomas. This is a benign tumor that is specific for the children, and meningiomas only in 8% of the patients. Sorry, I have problems here with the presentation. I will try to